Hi, I'm John Carlson, and I'd like to welcome you to the APA Psychotherapy video series. Hi, I'm John Carlson. I'd like to welcome you to the APA Psychotherapy series. This series is on relationships, and this program is on sex therapy with middle-aged and older clients. Our guest expert is Dr. Barry McCarthy. Welcome, Barry.
Nice to be here.
Just what is sex therapy? I mean, how do you define it?
Well, I define it as a subspecialty of psychotherapy, where what you're doing in sex therapy is you're looking at individual factors, couple factors, and sexual function and dysfunction. And so the notion is to integrate those sexuality issues in general therapy and to try to have sexuality play that 15 to 20% healthy role in a person's life and a person's relationship.
Now, isn't sex therapy and sexual problems the same irregardless of one's age?
Absolutely not. That one of the realities is as you age, you learn a whole different way of approaching intimacy, non-demand pleasuring, eroticism, and you learn a whole different set of positive expectations about sex and aging. So we want people to be both positive about it and realistic about it. That you can be sexual into your 40s, 50s, 60s, 70s, and 80s. But to do that, you've really got to learn a much more complex, more intimate, more interactive way of being sexual. And you've got to be more aware of your body and its changes, being an active patient, and also be aware of medications, medication side effects, and how that affects you sexually.
So it's really very different. Your sexual experiences as a teenager and early adult are going to be very different as you progress through the life cycle.
Very different, and that's especially true of males. One of the things that I often say, and I think there's very good data on this, is that when couples stop being sexual, it's always the male's choice. It's done non-verbally, it's done unilaterally, and basically the man says, if I can't function the way I did in my 20s and 30s, sex is too much of a disappointment, a frustration, and I just want to stay away from it.
Wow. It would seem, too, that older people are really challenged by medications and illnesses, and they all have sexual side effects.
They do, but you want people to be doing two things. One of them is you want to reinforce this basic concept of each person is responsible for his or her own sexuality, your own desire, your own arousal, your own orgasm. And then you've got to work together as an intimate team. One of the things I like about the issue of sex and aging is that it requires you to be a more intimate, interactive team. I think of sex as more human and more genuine. Now, in terms of medications, the issue becomes to be an active patient, to understand what's happening to your body, the medications, the side effects of medications, and to understand and work with a physician. I always encourage couples to go to the physician together to talk about medically, are there things that we need to be aware of and can fix? And ask the physician to do what they can do and what a medication can do. But you can't ask a medication or a physician to do more than they can do. That the reality is, the essence of sexuality is the psychological, relational, and especially psychosexual skill factors. And that's what you need to refine as you age.
On a personal level, how did you get into sex therapy?
Well, when I got my PhD from Southern Illinois University in 1969, that was just when Masters and Johnson were publishing their material.
It was a best-selling book, I think, then,
it was
on the
a
New York
best-selling
Times
book.
list.
And it was really incredibly important breakthrough material. And I have great respect for Bill Masters and his work. And at the same time, people were starting to be trained in the field, and there were only 7 university courses in human sexuality. And the university I was teaching at allowed these new professors, they gave them $1,000 if they developed a new course. So I developed an undergraduate human sexual behavior course. And over the years, the field has so changed and evolved. The knowledge base is so much greater.
Mm-hmm.
And I found it a fascinating field to be in.
Mm-hmm.
Intellectually fascinating, emotionally fascinating, and professionally fascinating.
Mm. Now, what is your model for working with people with sexual problems? Does it follow steps and stages?
It does. And the typical format is to approach it as a couple issue. So the first session, if possible, is to see them as a couple. The second session is to see them each alone once to do a detailed sexual history. Then to get them together and to do a feedback session where you talk to them about a new understanding, a new narrative about their relationship, their sexual problem, and also a plan of how to address the sexual problem. And usually also give them a specific exercise to do at home to re-engage them around sexuality.
Is there like a theoretical model that goes over this? Because I'm hearing about narratives, I'm hearing about behaviors, I'm hearing...
Well, I think about it as an integrative couple model that looks at, again, psychological factors, relational factors, psychosexual factors, as well as physical factors. My own orientation is a cognitive behavioral orientation, but certainly you can do sex therapy from very different orientations.
Sure. So how does change take place then with your model?
Well, I think the easiest thing to change is people's attitudes. I think the second easiest thing to change is their behaviors. I think the hardest thing to change is their emotional reactions. But I see the change process as being integrative, and part of that change process is being able to identify whether it's a lack of information, whether it's shame and guilt about past sexual experiences, whether it's a sense of alienation and anger at the partner, to confront those and hopefully to change them, and if they're not changeable, to figure out how to work around them.
Now, I would imagine that many of our viewers are interested in working in this area, but are not really sure where they start, because they probably didn't have a class. I know in most schools there are classes, but often they're electives. They're not part of the core curriculum. So how would someone start? Where would they get this information?
Well, I think for most people, they have a primary identification like as a psychologist, and to think of sex therapy as a subspecialty skill. And like other subspecialty skills, you go to specific training programs. There's two very large sex organizations, the Society for Sex Therapy and Research and the American Association of Sex Educators, Counselors, and Therapists, that have courses, that have conventions, that have continuing education programs. So to think about this as, again, a subspecialty program.
Where you can get certification from these groups?
Right. You can get certification, get supervision from these groups. That, my encouragement is to get more psychologists and more therapists involved in the sexuality field. I think they've stayed away from the sexuality field because of the feeling that it's now medicalized, or they've stayed away from it because of the controversy and the value-oriented issues. But in fact, individuals and couples are having as many or more sexual problems than they did back in 1970 when Masters and Johnson began. So it's a field, there's really a need in terms of serving people and also in terms of professional growth.
So this brief approach that's been put forth for middle-aged and older clients of taking the little blue pill and everything will be better, it doesn't sound like that's what's happening. People are not happily ever after.
That's exactly right, for two reasons. Again, Viagra, Cialis, and Levitra are excellent drugs. I am in favor of those drugs in many cases. But the issue is, you've got to integrate the drug into the couple style of intimacy, pleasuring, and eroticism. The woman needs to be involved in this. She's an intimate partner in it. Secondly, you've got to change expectations. Among successful users of prosexuality drugs, 60 to 80% of the time when they take the drug, they have successful intercourse. It isn't 100% of the time. And the marketing people spend their money, and it looks like it's 100% of the time. That's not true scientifically. It's 60 to 80% of the time.
Yeah. And so when they were younger, they probably had 100% success rate, and now they take this pill and they're 60 or 80%. Things are better, but they're not right.
They're not perfect. But again, the way men learn about sex, they learn it as easy, predictable, totally in control. But the biggest issue is it's autonomous. They don't need anything from their partner. That as both men and women age, they need more from their partner. That sex becomes more intimate and interactive. The idea that and I think that that's a better quality sex than the teenage autonomous sex.
Barry, now it's time in our program where our viewers get a chance to watch you do therapy. You're going to be working with a middle-aged woman, Alita. Can you set that up for our viewers in terms of Alita, her problem, and your therapeutic interventions?
Well, I think Alita is a very interesting client. She's coming in alone. Her husband is too afraid and anxious to do this.
Oh, okay.
And we will be talking with her about her attitudes, her experiences, and her feelings about a very difficult issue now in her life. There's been changes medically, there's been changes, and dramatic changes in their sexuality. And that where sexuality had been a forte in their relationship, it is now a major drain. What I'm trying to do is to provide her with a different way of understanding herself, the sexual problem, and also confronting her with some of the things that she is doing and feeling which are really unhealthy, both for her and for the relationship.
So you're going to listen to her story and then trying to modify it and give her some ideas about what she can do that's going to be different.
Right.
Okay. Is there more?
Well, ideally, one of the hopes is that this will allow her to see it more clearly, and instead of being as frustrated and adversarial with her spouse, to be able to feel that she can have a positive influence with him and get him involved in the change process.
So then there's some empowerment that's going to take place.
That's the hope. That's absolutely the hope.
Well, let's watch.
Good. When you think about the sexual worries and concerns that you have now, as opposed to the worries and concerns you had before your husband's surgery, in what way are they different?
Actually, for me, they're not different. I believe they're different for him.
Okay.
There's a couple issues. My husband just had open heart surgery.
Right.
I think he needed, the first time we were together sexually after surgery, I think he needed to prove to himself that he wasn't going to die if we did anything, and the fact that everything still worked. I think that was the scary part for him. But
And what about for you?
I was happy for him that everything went the way he wanted to, but there was other issues prior for us. And this is what I want to ask about the most.
Okay.
Our sex life was always incredibly good and passionate, and you know, it was like a daily vitamin. It kept us both happy and healthy.
So one of the fortes of the marriage.
Yeah.
Okay.
And then 4 years ago, I had a hysterectomy.
Okay.
And it's almost like they not only took out my female organs, but they took out my drive. And mentally, my drive's there. But physically, I don't know if I was told I have lots of scar tissue and things like that. I was used to reacting a certain way and feeling a certain way when he would, touch me or be in me or be around me, and those sensations weren't there. And that was disappointing to him. And we've never quite gotten it back to where we were supposed to be or where we used to be, because he was kind of like, oh, well, I'm broke.
You're broke.
I'm broken.
And did you agree with that you were broken?
No, not at all. And we got it was always something we were going to get to. Okay? That, I mean, he never came out and said, gee, you're broken. But it's pretty much, if you're not feeling what you used to feel, then, you know, I don't need to spend so much time with that. Whereas I kept feeling like, gee, if you would have spent more time at that, you know, trying to get me to feel more into climax and to get to orgasm, that I'd get healthier quicker, almost like a rehabilitation program.
Well, that's actually a good point.
We never got to that. And then I believe I kept pushing harder for that, and then the frequency was just getting more and more, because instead of being something enjoyable and an extension of how we felt about each other, it became, gee, is it going to be okay this time? Gee, you know.
And okay meant you were going to feel desire, or okay meant was it going to be painful, or okay mean was it going to be orgasmic? What did okay mean?
All of those. Okay, back to where it was sensual and fun and passionate and enjoyable for both of us. You know, there was no question before. You know, I luckily spent most of my life being able to have no problem with orgasm. In fact, I would be able to, I guess the word would be ejaculate kind of thing. You knew if I came. You know, now I can think it till I'm blue, and it's like somebody turned off the faucet.
Well, let me see if I'm following this. So you're saying before the hysterectomy that for you, desire, arousal, orgasm, and a sense of satisfaction was very easy and very predictable.
Absolutely.
And when you after the hysterectomy, did you all, in terms of rehabilitation, either with the physician or without the physician, talk about what the changes were going to be?
Nobody ever mentioned that part. I was ready for everything else, but nobody ever mentioned the desire part. You know, at all. I wasn't ready for that.
So, but a change in desire.
Yeah, I figured nothing could change that in me. I figured that was a staple of my personality, and you know, it's there mentally, but the rest of, like, the thought and all the things that would happen after it just aren't what they used to be. Now, I'm not saying they're not going to stay that way. I'm sure that they can come back and be equally as good but different.
Different, right.
Okay, equally as good but different. But during that point in time, that's when I believe my husband started getting really, really sick. So, and he never even mentioned about being sick. There were no symptoms. I figured this sexual thing between us and the working, you know, all of this was just part of it. Now, there wasn't animosity between us, but, you know, there wasn't. And, you know, do we love each other? Absolutely. Absolutely.
Which is obviously a really good resource to work from.
It is, but it's lonely because it's important to him and it's important to me.
And before the surgery, in terms of before his surgery, was it a kind of a downward slope, or was it like a roller coaster? There'd be good times and bad times.
No, downward. I mean, very, very different.
Very dramatically.
Very dramatic difference. And there were other issues, say things that would come up that were not him and I. Things around us, family issues around us.
So all kinds of external stresses.
Oh, tons of stresses, tons of them. And I figured, well, you know, there's times that you just need to be a little patient, and, you know, this season, if you want to call it that, will go away eventually.
I want to come back to that, but just to give me the full picture, was his open heart surgery a real surprise to the two of you, or did you see it coming?
It was a huge surprise to him. I saw something, I knew something was wrong. I didn't know what it was, you know, because I went through all those things where I thought it was me. You know, I thought, gee, I'm not desirable anymore. Gee, I'm not sexy anymore. He would say things like, you know, gee, I'm just a really visual guy, and, you know, you just don't look as beautiful as you used to. You know, and I, you know, take that to heart. And then I think about it going, wait a minute. You know, it's like he's pushing me away for some reason, but I don't know what. And I would tell him, I said, I still feel wonderful when I'm not around you. And I mean, it's not being mad to him. I said, I still feel like, you know, hey, I'm okay. And then I get around you, and it's like I'm not 35 anymore.
Right. Neither of you are 35.
Well, no, I know we're not.
Right.
You know, and I think it's unrealistic to do that. But now, since he's been sick, I realize he didn't know what was going on, and that was his way of pushing me away and not needing him so much, because what if he wasn't there? And we've talked about that since. And he still is scared about that, about dying and leaving me with the two little guys. So now there's just not issues at all of just sexuality, even though I look at this as sexuality. This is all wrapped up in it.
It is all wrapped up in it.
He doesn't want to leave me in a lurch.
And unlike with the hysterectomy, did you two go together to the coronary person and talk about both the medical and the psychological and the relational aspects and the sexual aspects?
Yes. Yeah. The biggest part with him, and it's been interesting, because the last time we went, because he's either right now he's grateful, or he's the ugliest, meanest man you ever wanted to see. That's what we're going through right now. And when we went to the doctor, I mentioned to the doctor about getting something for depression to get him through this part. And he lashed out at me, not the doctor, my husband, meaning, you know, well, look at, there she is being bitchy, there she is being mean, you know, and then in the next breath he's like, I don't know what to do without her.
Well, both things are true.
Yeah.
That he definitely wants you and wants the relationship to be going, including sexually. But it sounds like the fears are
huge.
Very much there.
Because we've only been together sexually once, and that was just enough for him to prove that he wasn't going to die. And I think to himself. You know, we seem to be more therapeutic.
And when you think about the year before your surgery, so we're talking about 5 years ago.
Oh, huge difference.
How often would you all be sexual?
Every other day.
Okay, so
We
that's
were one
a
of those
good,
couples.
healthy rhythm.
Oh, yeah.
And between your surgery and his surgery, what was the rhythm, what was the frequency of sexual contact?
4 or 5 times a year.
Okay, so it's a dramatic difference.
Dramatic.
And since his surgery, you've been sexual once.
Yeah. Do I like it? No. That's why I'm here.
Right.
Yeah.
But you know, let me say one thing kind of to reduce the stigma. And that is the operational definition of a non-sexual marriage is being sexual less than 10 times a year. And about 1 out of 5 married couples have a non-sexual marriage. And when couples stop being sexual, it's almost always the man's decision. That he feels either too scared or too frustrated or too upset and says, I just want to back away from this.
Okay.
So what you're experiencing is difficult, and you shouldn't necessarily just accept it as difficult, but it's not as infrequent as you might think it is. There's also one of these cute one-liners, and cute one-liners, of course, are always way too simplistic, and that's the concept of use it or lose it, that the more couples stay away from being sexual, the more they become self-conscious. And it sounds like that has happened in the last 5 years.
Yeah.
So it's like you've had a 1, 2, 3 combination.
We have. We have. Do I think that it's hopeless? No, I don't. I think this is just a time to be endured, learn from it, and get through it. Do I think there's some things that need to happen? Yeah. And I went up to Mayo Clinic 2 years ago, and they put me on estrogen and then gave me a vaginal pill that I had to put in there, because they said what had happened is I had so many scars or incisions, vaginal incisions, that the skin had all atrophied. So that's where the pain was coming from. And my husband was afraid of hurting me. You know, instead of saying working through it, he was lovingly scared of hurting me.
So it was a kind of a loving avoidance.
Yeah, it was. He didn't want to put too much pressure on me, and then the other stuff started falling into place. And my projections for fixing it will be once he comes to terms with himself and getting healthier and getting happier, he'll be more open to getting that part of our lives back.
Mm-hmm. And meanwhile, what are you hoping that you'll do, what your role in this will be?
The role I have now. You know, I'm his wife.
Mm-hmm.
You know, would I like it to be different? Yeah. Do I think that now is a different season in my life? Yeah, I do. Do I want to get back to where we're far more sexual and fun-loving and the freedom with that? Mm-hmm. Absolutely. Do I think it's reasonable to think it's going to happen tomorrow? No, it's not going to happen tomorrow. Well, do I think it's going to happen? Yeah. Yeah, I do. I do. But I think there's a lot of things that need to get worked through, and I believe that's going to happen within the next year. You know, but yeah, it'd be nice to have an orgasm again. It would. Mm-hmm. Do I think I can? Yeah. But not as easily and not the way I know it.
Right. But you know, it sounds like there's a his part of this, or her part of it, and then an our part, and especially an our with accepting the physiological realities, both of the medical issues and the aging. Mm-hmm. That what you want to do is you don't want to turn the clock back to the way it was 5 years ago.
No.
What you two want to do is develop a couple sexual style now that fits you.
Right.
And will fit you into your 50s and 60s and 70s.
Right. Right.
So we do want to take an optimistic approach to this.
Yep, I do.
And we don't, but the danger is we don't want to treat it with benign neglect so that you get used to the self-consciousness mm-hmm. and you get used to the avoidance.
Mm-hmm. But that's something that I can work on it all I want by myself, but there's mm-hmm. very definitely a time where I want him to be involved in that. Right. And I just think the fears that are there right now are so huge for him that's not even... That should be a part of your life that gives you joy and makes you relaxed.
Right, that allows you to feel more energized and more satisfied. And
instead, because of everything that has transpired, mm-hmm. it now becomes another work or obstacle. Mm-hmm. And I would rather have it not happen for a while and then get it back to where it's joyful.
Mm-hmm. It's got to be a different kind of joyful.
Yes. Absolutely.
Let's talk a little bit about that, about mm-hmm. what it would look like. Mm-hmm. From your point of view, let's look at your part of it, then we'll look, mm-hmm. even though he isn't here, we're going to look at his part of it, and then let's look about rebuilding a new comfortable sexual style. Mm-hmm. When you think about post-hysterectomy, mm-hmm. it sounds like it had one of the big effects is that kind of easy sexuality disappeared.
Right, right.
And are you the kind of couple who got into this pattern of it's intercourse or nothing, and if it isn't intercourse, nothing wins?
No.
Well, good.
We were fun. I mean, mm-hmm. that was like just a really wonderful, lovely thing we had together.
Right.
So it was always something different. It was always something, I guess the word would say, fun. You know, whenever we could get the time or the place or, sneak it in and crazy. Yeah.
Has there been experiences where you say it's really been fun?
No, because it hasn't.
Right.
If I'm going to be anything, I'm going to be honest with him.
Right.
Yeah, it hasn't. It always seems to be too forced.
But you're part of it. Again, mm-hmm. not his, but yours. Mm-hmm. Do you see it being primarily about a desire inhibition, about not looking forward to or feeling like you deserve sex to work in your life? Or do you see it more the issue about arousal in terms of not either feeling physically aroused or subjectively aroused?
For me, it's used to sexuality being, arousal coming one way, right. and it doesn't come. The mind says yes, but mm-hmm. then the rest of it doesn't, and then when you do get...
What was the one way it used to come for you?
When I would get aroused, you'd become wet, things would swell, it would get comfortable. Your body would feel good.
Right.
And now...
And your orgasmic pattern was easy and reliable?
Oh, yeah.
And typically, was your orgasmic pattern during manual stimulation or oral stimulation or intercourse stimulation, or all those kind of stimulations?
All three. I could think of myself into it.
Okay.
And it wasn't ever fake. You hear about people faking it, and I never did. I never had to. And after the hysterectomy, it's like I went to go use the car, and the car didn't run anymore. And I called the doctor and was like, my God, what is this? And he's like, oh, it'll get better, it'll get better. It didn't. It got better after I went to Mayo's and got the hormones. But by that point in time, I believe my husband was starting to get sick. Plus, he was scared of hurting me.
Plus the rhythm was gone.
Yeah, absolutely.
Because one of the best ways of understanding this new chapter in your life sexually, and I think that is not a bad way of thinking about it, not comparing it with the old chapter. You want to have good memories of the old chapter.
Oh, yeah.
But you don't want to make the comparison.
You can't compare them.
Right. You want to.
They're completely different.
You've got to find
We're
a new
different
chapter.
people.
Right. Absolutely. And one of the best ways to think about this new chapter is to think about sexuality as something that has a biological component, a psychological component, but also very, very important, a relational component of you all being intimate sexual friends with each other.
Right.
And it sounds like there's a lot of love and stability in the marriage,
but pulling
which
away.
is the plus. But a fear and an avoidance too.
Yes.
And in a funny way, the old memories of the way sex was up until 5 years ago is more of a burden right now than it's a facilitator.
I never thought about that. But yeah, it's...
And again, it's not to negate those years.
No.
But it's to say we really need to find a new way of thinking, talking, experiencing being sexual.
I think it's real, and in this way my husband and I are the same. I mean, we both thought of each other as, sex was always easy, sex was good, for together as well as apart. We always were very confident in those areas of our life, apart from each other. And for me, and I believe for him, it's hard to give up that confidence. It's hard to relearn something that you knew how to do well.
Right.
It is. It's
I have great empathy for that. And yet, if you're going to return to a healthy kind of sexuality, you're going to have to build a new comfort and confidence. And part of that new comfort, did you like your gynecologist? I mean, did you find the gynecologist helpful to you?
The one in Minnesota, yeah. Do I need to find one closer? Yeah, I haven't seen her in 2 years.
Because part of what she said sexually makes sense. And part of what she said sexually is absolutely incorrect.
Yeah, I haven't gotten any real good... I'm constantly trying to find something to read to fix it. And I figure I can't be the only one, but believe me, there's no books. You type in on the computer sexuality after complete hysterectomy. Not much comes up.
Well, there's actually a number of really good resources, and we can talk about it at the end of the session, and I will give them to you.
Okay.
Which is it's a good thing to have. There are some really excellent resources. So that's one thing.
Okay.
Let's not forget about. But at this point, let's try to focus in on what you can do, let me say a couple things of what you could have done, but you can't turn back the clock. But in essence, what happens is that if you continue to engage physically, sensually, erotically, that in fact, it's like a rehabilitation. It would be like any other thing, an arm problem, a knee problem. You've got to actively rehabilitate it. If you just let it go, the arm, the knee, but also the vulva, right? It atrophies. But the major thing that happens psychologically is that you become incredibly self-conscious, and there's nothing more anti-erotic than self-consciousness.
Right, and I hate that part. I hate it.
Right.
It's not me. It's not part of who I am.
Right.
And I really need to come to grips with that one.
Right. And one of the best ways of coming to grips with that is to be able to say to yourself, as well as to your husband, that we've got to reapproach this together in a new way. And to do that, I need you to be my intimate sexual friend. That doesn't help me when you're self-conscious and afraid of me. It doesn't help you when I'm afraid of you and your worries. We've got to do this together, and we can do it, but we can't do it in the old way. We've got to do it in a new way.
So what are your suggestions?
Well, I'm suggesting a couple of things. And one of them, obviously, is not just for you to read the stuff on your own, but the two of you to read it together. And in terms of your part of it, is that would you feel strange finding a gynecologist or an endocrinologist who was pro-sexual, who you could comfortably talk to, where he would come with you to the appointment? You'd have to do the exercise.
That'd be fine.
See, I think that could be enormously helpful, where you're both dealing with the same information. And part of that information is that for the great majority of women over 40, but certainly almost all women over 50, that even when they're feeling subjectively aroused, their body simply doesn't respond as easily objectively. That's true of his penis and his erection. That's true of your vulva and vaginal lubrication. So that one intervention that people often do is they get comfortable with using a lubricant and using it prophylactically. In other words, using it before you begin the sexual experience. And
I've done it. Go ahead.
And what I often suggest people to do would be to choose a lubricant together, to go together to a place like Crabtree and Evelyn. If you don't like that kind of place, go to your local drugstore.
The almond oil.
Right.
Yeah.
Find something which is water-based, hypoallergenic, and it feels and smells good. Not instead of stimulation, but in addition to it, and doing it before you all begin.
One of the things that I know he enjoyed and I enjoyed is when he would go down on me.
Right.
And when you use the lubrication ahead of time, then we were using oil and
oil is usually not a good thing to use.
Yeah, because it's
but
not
in
any good that way.
terms of doing oral sex, again, one of the best predictors of sexual response is feeling open and responsive to oral sex. So that what most couples will do is that it's a both and approach, not an either or approach. So to be doing oral sex and then intermixing that with manual sex using a lubricant. So you get both, the advantage of both. It also seems to me what most people find, you have to think about you in this new phase of your life, not the way you were 5 years ago.
That's real hard to do because that's the only point of reference you have.
But it's going to be in a new important point of reference.
Okay.
And that is, when you most people find is if there's a 10-point scale of arousal, 0 is neutral, 5 is you're beginning to be aroused, 7 is high arousal, and 10 is being orgasmic. I mean, it sounds like what you're saying is that for both of you, it really flowed very easily. I mean, it was just, you got into a really nice erotic flow.
Oh, yeah.
And
no, I
wasn't
mean, that
any
was just like an easy gift.
Right, right.
Because remember, on top of my surgery and his surgery, We've got 2 kids,
Right.
4 kids, 2 dogs,
Right.
in a company we run together.
Right.
So, you know, it
There's
just...
a lot of factors.
Yeah.
You're not a young
Right.
couple without kids.
No.
Right.
No, not at all.
But that's part of your new sexual style.
Okay.
And part of it too
Get
is I
used
would
to the dog
imagine in
licking
the
your
old
feet,
day,
huh?
in the old days, you could be sexual, whether it's
Exactly.
at midnight, or is
Exactly.
it noon, or is it
There was
6 in the
always
morning?
time, always, you know, if you could find 5 minutes or 4 hours, we would fill it.
Right. I think in a new style, you're going to have to be alive, alert, and awake. And you're probably not going to be alive and alert and awake at 6 in the morning or at midnight.
Right.
And that you might well have to have dates that are both spontaneous and planned. Like when your kids are at soccer practice, you want to show up for the game, but you don't have to show up for the practice. You can go home for the practice and be sexual. So you're going to need, and some of that is different, but in fact that mix of spontaneous and planned dates is what most people who have a company, 2 dogs, 4 kids, 2 cars, and life, you never see that in the movies, right? In the movies, it's always
no.
a young premarital couple or it's an extramarital affair.
Right. Right.
And again, it's a different style. It also seems that one thing that might be helpful, both in terms of your new sexual voice and his comfort level, is more consciously deciding, and I think the time to talk about sex is outside the bedroom, not inside.
Yeah.
It's always easier, I think, to talk sex on a walk while you're gardening together over a glass of wine than it is, especially after a difficult or uncomfortable sexual experience where you're laying in bed nude. You're more vulnerable there. It's easier to have hurt feelings. Is the idea that on a regular basis that you'd be the one who would make the transition from erotic stimulation to intercourse, and that you'd guide intermission, because it would take away from him his worry about hurting.
Say, no, he used. I mean, it was both of us.
I understand that. Yeah,
before.
I understand.
Yeah.
But I'm wondering, in terms of trying anew, whether that would be helpful both for you and for him.
Could be. I'm open to anything.
Okay.
And when it comes to some of the issues that he pulls me or pulls away from me from, I'm not going to say that I'm not a little angry about it. So there's times when being close to him is just, I'm beat. You know, it's not worth the effort. I want to put myself out there as much as I can. Yeah, it just, there's times where I love him dearly, but I'm just so overwhelmed with so many other things that.
And it sounds like frustrated with him.
Oh, I am.
In truth.
I am, because I know how intimate and loving and dear he can be. And when he's not with me, I feel like that's a choice he's made. I don't know if I'm being too judgmental there or not, but.
Well, you know, it'd be interesting, because my bet is if he were sitting here,
He'd probably say the
would
same thing.
No, I think he would say it wasn't a choice.
Okay.
It was basically a worry, an embarrassment, a fear, and the avoidance just feeds itself. That one thing about rekindling sexual desire is it's an anti-avoidance approach. Avoidance really does feed itself.
All right, he didn't know he was sick. I knew that there were certain little things, about the person you love. There's just.
So you were more aware than he was about
absolutely.
his physical issues.
And any physical issues, every time to this day when we still go to the doctor, the first thing he talks about is how many miles he walked, how much he could run, all that macho kind of stuff. The man just had open heart surgery May 3rd. Nobody cares how many miles he runs. He wants it to be over with. He wants it to be right back there to be like it never happened. Okay, he has a huge frustration with it being taking longer to get healthy. Okay, I think he hasn't forgiven himself for not being invincible. Okay, that's his personality. I think we're just real lucky that he listened to me for once, and you know, I kind of drew the line in the sand and said, that's it. You know, if there's nothing wrong with you, you know, I think you're acting inappropriately, not only with me, but the kids and work. And you could tell the man was just tired. I thought he had a lung problem. I mean, so was I real surprised? Absolutely. But it's one of those things, while he was sick, I had to run the company. And while he, you know, everything went on my shoulders, of which he hated that. So it demasculated him in his eyes, not in my eyes. But it seems like he's dealing with those issues. And if I was the one guiding our sex life one way or another again, and not him taking the lead, it would just be another issue that I didn't leave to him.
But you know, one of the things
I'm just saying,
I understand
you know
what you're saying. I very much understand what you're saying. But one of the most interesting things about aging, even if there isn't any hysterectomy or a open heart surgery, is that when couples who are sexual in their 50s, 60s, and 70s, sex becomes a more intimate, interactive experience. They need each other more. In a way, sex becomes more human. And that's, it seems to me, the challenge for the two of you.
Yeah.
Not the only challenge, because it sounds like there's a million challenges, but that's one challenge.
See, that's how we were. We needed each other.
Right.
I used to say I needed him,
and in a
I
funny
still
way,
do.
you guys need each other. You're more afraid
Of losing
You're more
each other.
avoidant,
Right.
but you really do need each other more.
Oh, yeah.
And you need to speak to the healthy parts of each other,
Yeah.
both in dealing with the physical vulnerabilities as well as building this new couple sexual style. So I'm not trying to make you the boss and him subservient, because that won't work at all.
That won't work. No. And that's not what I want.
Right.
Yeah.
But it seems to me that what you need to be able to do is, again, this both-and approach. And that is to talk about the business, talk about the health issues outside of the bedroom, outside of the sexual situation. And not expect that, okay, if we deal with that, then the sex will automatically take care of itself. We're going to also have to address the sexual issues.
Can I ask you a question?
Sure.
Okay. We've that's a huge part of the turnoff for me, because there's been situations when we should have been intimate and like we, you know, in our hot tub or in our bed, and all he can talk to me about is work. You know, it's almost like if I had a penis, it would go poof. You know, it's just, you know, in the middle, I want to hear that, you know, oh my God, I need you, I love you, all the stuff he used to say.
There's nothing personally invited.
Hey, no, you know, hey, did you pay that invoice to so and so? You know, it's like, oh, forget it.
Right.
You know, and
it's like it
disappointing.
poisons sexual desire.
Oh, it does. It does.
But part of that is awareness on both your parts about what poisons the desire. But it's also going to be important to build new bridges to desire. And some of those bridges can be spontaneous, but I think they're going to need to be
Structured.
more planned, semi-structured, not rigidly structured like a chore, but where you all try to build these bridges to desire and stay on the same team. And not hope it's automatically going to happen. So you're going to have to deal with both
Right.
the business, the health, and the intimacy and the sexuality. And you're going to have to use all your resources. And that's going to mean physicians. And that's going to mean each of you being able to say to the other one, I'm going to take better care of me in terms of my desire, my subjective arousal, my enjoying pleasure. And we're going to have to be okay with the idea. You know, one of the great things of the old sexual relationship is it sounds like it was 100% predictable.
It was good.
Right, and I think that's a great thing. I truly do.
Long after, it'll keep me smiling when I'm old.
Right.
Yeah.
But what you really, I think, want to smile when you're old.
I want my husband back.
Is to have your husband back and have a new kind of intimacy and sexuality that feels like it's nurturing your life and nurturing your bond.
He's scared to death of getting old. He's scared to death of not getting old. Right now, he's scared to death, period.
Right. And again, in terms of that being scared to death, both sexually and non-sexually, what can you do that would be helpful, and what does he need to do independently that would be helpful?
I have no idea, because everything I've tried, if it even seems like it's working a little bit, he'll take offense to some things. It's just crazy. You know, it seems like he's just not relaxed enough to just be happy right now. And he wants to make me happy, but he's not happy with him, so he just doesn't know what to do. And if I push the issue at all, he just says I'm bitchy.
So it becomes almost
it's a
more
vicious
of a
circle.
power struggle than it is trying to be positively influence each other and to be supportive of each other.
You know, the times where he gets aroused now is when other men find me attractive. Then all of a sudden I'm this new entity. I'm a different person than the person that he knows. But we're not around that many other people. You know, so it's not like it happens all the time.
But it's also an affirmation that you ought to take seriously about your attractiveness. That your positive attitudes about you, your body, the marriage, sexuality, and touching is a good thing for this relationship, not a bad thing. And that's a really important thing, I think, to remember. That you are going through a hard period. But you don't want to negate your good feelings and think that'll make it better. It'll actually make it worse. Because I think what happens is if you start negating, it'll make it easier for him to negate.
Okay. When does it become easy enough or healthy enough to expect him to have responsibility into this?
No.
Okay.
But it's got to be a responsibility. You've got to feel that there's things you can do that positively influence. But there's also got to be a respect of him that says that you believe that he can come to grips with these fears. But to come to grips with these fears, he can't do it either sexually or non-sexually in his super macho way. You know, John Wayne was great in the movies. He's not great in real life.
Right.
The most typical suggestion, non-sexually, is a suggestion of him joining a support group of men who have had heart conditions.
I'm trying to get him there.
Again, the question is, he can't do it for you, he's got to do it for himself.
Right.
And it's much more likely to come whether it comes from information from the physician or from the internet, information that says, this is a healthy, good resource, and people like myself get... And rather than seeing it as open-ended, one of the values is that some of these groups are time-limited, and males are much more likely to go to those groups.
Well, I think on the tape we mentioned when I was at the doctor with him, I'd mentioned about his depression to the doctor, and he lashed out at me like, no, there wasn't anything. The doctor suggested, or kind of tried to play down him getting upset with me, and I said, do you think if this goes on the next month that we'll be able to at least meet me halfway and, we'll gauge it, and if you don't seem to be bouncing back at all after a month, now this isn't sexually, this is just in his attitude, that we'll try something. to help with that.
But rather than saying to him, I'm the boss, try this, I think what you need to be able to say to him is, here are 3 or 4 options that have worked for other people. It's ultimately your decision of which option you want to take, and I'll support it. But we need to take an option.
Well, let me ask you this. I mean, this is going to sound... I think it's the best thing I ever did for our lives, but I threw him out 2 weeks ago and packed all his clothes. He wasn't listening to me. He wasn't listening to himself or anything, so I packed everything he owned neatly, but put it in suitcases and took it over to, 'cause he was spending all his time at the office and not coming home, and put it in the car and said, look, I think you need some time by yourself, away from us, away from making us miserable and yourself miserable, and figure out what you want for your life, and if you want us in it, fine, and if you don't, fine too, but this can't go on like this. And I didn't, go after him for 2 days. He's home now, but he still just looks at me and goes, you took all my clothes out of this house. And I'm like, I needed to, kind of what you said. It's like, I want him to make decisions. I want him to set goals for us. And through those things, I think the self-esteem will come back to where our sexuality will come back. But somebody had to stop it.
Sort of the tough love approach.
Yeah, you know what? I didn't know what else to do. I figured something had to happen because I really do love this man.
Right.
And I do love my marriage with him. But the things we've been living are wrong. Now, did I expect him to be gone? No, not very long. But do I think he needed some time away from the whole circus and the whole thing, and to really come to grips with what happened to him, which is a big thing. I have a whole complete life away from him.
Right.
I don't know if he really thinks of his life away from me and the kids. I just there's some parts that need to get looked at, and I'm hoping that will be the beginning of that, and I think it is, from what I can see in him.
I think that would really be good, and I think that's what you want to build on, both inside the bedroom and outside, to make that happen. And the two of you have to have a plan that you both respect, so you know where you're going. You have business plans. You also need a rebuilding confidence plan, health-wise, and you need a plan about working together. And so my hope would be that you would not just take this as okay, I've got an idea, but you're going to need to follow up, and he's going to need to follow up.
Yeah.
But I think your basic insight is right, that this is a relationship, a marriage that you really value. And I think your optimism that you can get it back on track is enormously helpful to you and to him. But you guys got to get back to...
It's hard. It's not... I'll be honest with, I never would have thought, if you... I'm not silly enough to think there aren't problems, but I would have never thought that this would have been one of the problems my husband and I have. Right. Never in a million years.
Well, I would imagine he never would have thought he would have had a heart attack.
Yeah.
Or that at your age you would have had a hysterectomy. But again, I'm one of those mental health people who says you're much better off dealing with reality rather than pretending it isn't true.
Yeah.
And it is true. Your life in many ways has been turned upside down.
Yeah.
And understanding, accepting that, and you can't go back to the 5 years, is really important.
Because I'm sitting here smiling. It's like there's times when I'll wake up in the morning, and I know when I tell you this, and I'll say, he's got his arm around me, and I'll wake up, and it's the Great Dane. It's like he's always got the dog in bed with us. Now I know how bad that is, okay? And so what was the answer to that? He said, we needed another dog. So now I've got 2 dogs in bed with us. You know, almost like he needs this buffer between us.
Except the problem with the buffer is that you get into the cycle of greater self-consciousness, greater avoidance.
Oh, yeah.
So again, I think it's important to actively follow up. And let's talk some now about the resources.
Okay. Thank you. We do okay?
Barry, is this a good example of sex therapy with a middle-aged or older client?
Well, there's some parts of it that are an excellent example. She's obviously very forthcoming, very blunt about sexuality, and that's a real plus. There's others that's not as similar in that most of the sex therapy is done as a couple, for example. But again, you have to take what is there, but the ideal model in sex therapy is to do it as a couple.
So you're kind of jumping ahead. My next question would be, where would you see treatment going? And it sounds like it would be to get her partner involved?
Ideally, that's what you would want to do. But you can't coerce people to come in. But you can certainly make it easier and invite them to come in. So that, for instance, I often will give the person a choice of whether they want to come in alone, come in as a couple, or speak to me on the phone. But I want to have some involvement with the spouse, if at all possible.
In the case of Alita here, where would you see treatment going?
Well, I think that Alita is at a really good point to be in treatment. That if they allow things to go the way they're going, it's going to get, the sexual problem is going to become more severe and more drain on their relationship. I think she's motivated at this point to address the sexual problem, but feels really stymied about what to do. And so that what I would be, again, suggesting, other than doing this as a couple, is to also get her thinking about what kinds of ways that she can influence her husband, where they can think about this as an individual. Each of them has an individual role, and they've got to work together as an intimate team in terms of addressing this.
Would you see this as a short-term, pretty easy, quick fix situation, or do you think it would take a longer time?
Well, you know, traditionally, couple sex therapy goes from somewhere between 10 and 25 sessions, 3 months to a year. If I were going to guess, and they were motivated and willing to follow up, that they'd be more in the 3-month to 6-month category.
Now, if you were to continue to work with them, I noticed one of your assignments was to suggest that she and her husband talk to a medical doctor.
Right.
Would you be a part of that conversation? I mean, do you ever work directly with the physicians if there's a medical problem involved?
I do work with the physicians. Seldom do I attend the meeting with the physician. Physicians are not used to seeing the couple together. So for the physician, it's really a stretch to have 2 people in the room. They're used to seeing people one-on-one. But when they come as a couple, it brings out the best in the physician. That the physician is more willing to talk about medically what they can do that fixes the problem. What the physician can't do is they can't foster intimacy and sexuality in the relationship. But they can talk about the medical factors, and that's really important, especially for this couple.
Well, it sounds like there's a lot that we can learn about sex therapy. And one of the best ways to learn it is to take some clips from the session that we just saw. So what we're going to do now is to pick clips, and the first one we're going to see comes from right near the opening. Actually, it is the opening. And then we're going to give you a chance, Barry, to let our viewers kind of get an insider's view of what's happening.
Okay.
So let's watch.
Good. Well, when you think about the sexual worries and concerns that you have now, as opposed to the worries and concerns you had before your husband's surgery, in what way are they different?
Actually, for me, they're not different. I believe they're different for him.
Okay.
There's a couple issues. My husband just had open heart surgery.
Right.
I think he needed, the first time we were together sexually after his surgery, I think he needed to prove to himself that he wasn't going to die if we did anything, and the fact that everything still worked. I think that was the scary part for him. And
what about for you?
I was happy for him that everything went the way he wanted to, but there was other issues prior for
Okay.
us. And this is what I want to ask about the most.
Okay.
Our sex life was always incredibly good and passionate, and you know, it was like a daily vitamin. It kept us both happy and healthy.
Sort of one of the fortes of the marriage.
Yeah, yeah.
Okay.
And then 4 years ago, I had a hysterectomy.
Okay.
And it's almost like they not only took out my female organs, but they took out my drive. And mentally, my drive's there. But physically, I don't know if I was told I have lots of scar tissue and things like that. I was used to reacting a certain way and feeling a certain way when he would, you know, touch me or be in me or be around me. And those sensations weren't there. And that was...
Barry, your opening question referred to surgery that her husband had had. Did you do an interview with her ahead of time, or do you take a complete history?
Well, typically what we try to do is we try to see the first session with the couple together, and then we do individual sex histories alone to get their perceptions and get a really good feel for them, both medically, psychologically, and relationally.
In the case of Alita here, though, you didn't have her husband here.
Right.
And so...
And Alita and I had talked briefly before our meeting began, so I knew about both of their surgeries.
Oh, okay. Now, she seemed really pretty open. Is that typical?
Well, no, she's probably in the upper 10% of clients, both in terms of being open and also her experiences being so positive and pro-sexual, which has its advantages, but as we're going to see, it also has its disadvantages.
Oh. Now, is the focus always directly on sex if you're doing sex therapy?
Well, I think good sex therapy is a subspecialty skill. It asks you to look at individual factors, couple factors, but also sexual function and dysfunction factors. So you want it to be comprehensive, but that's right, you shouldn't lose your track on sex. And so often, I think, in more traditional individual and couple therapy, they lose their track on sex. And in sex therapy, you try to keep that on track.
Yeah, and for some people that could be pretty uncomfortable because sex is a topic that we don't always focus on. And I've watched people, when they bring it up, they try to get away from it.
Right. But you know, when you think about traditional histories, you always ask about family of origin. Yeah. I think you should also ask about past and present sexual functioning. And that'll help you desensitize and see sexuality as one of the things that you ought to inquire about and be ready to intervene about in general therapy.
Okay. Now we're going to watch another clip, Barry. We're going to get a chance to see where she talked about sex being different now.
Okay. Well, let me see if I'm following this. So you're saying before the hysterectomy that for you, desire, arousal, orgasm, and a sense of satisfaction was very easy and very predictable.
Absolutely.
And when you after the hysterectomy, did you all, in terms of rehabilitation, either with the physician or without the physician, talk about what the changes were going to be?
Nobody ever mentioned that part. I was ready for everything else, but nobody ever mentioned the desire part. You know, at all. I wasn't ready for that.
So, but a change in desire.
Yeah, I figured nothing could change that in me. I figured that was a staple of my personality, and you know, it's there mentally, but the rest of, like, the thought and all the things that would happen after it just aren't what they used to be. Now, I'm not saying they're not going to stay that way. I'm sure that they can come back and be equally as good but different.
Different, right.
Okay, equally as good but different.
So Barry, as we watch this clip, what are you hearing?
Well, the thing that I'm hearing is trying to understand and help her understand the difference in the past before these surgeries and now, and the difference between objective arousal and subjective arousal.
What do you mean by that?
Before, for both of them, he got easy desire, easy erections, easy orgasms. She had easy desire, easy lubrication, easy orgasms. And there's some great things about that. But now, as they're adjusting, not just to the aging process, but these two major surgeries, and their kids and life, they've got to look at a different, more complex way of understanding their bodies and their sexuality, and they haven't been able to do that so far. So we're trying to get her thinking about that.
And there seems to be so many events that go on in lives, especially in our older lives, medical problems or social changes or losses that directly affect our sexuality, yet they're not addressed.
Absolutely, and especially by the physicians. Physicians tend to stay away from sexual issues. In that, the way I think about sexuality, I think about it as a psychosocial bio approach. But if there's major biological changes, and that is one of the factors with aging, with medications, with surgeries, you want to help the person to be an active patient, to really understand what's happening to their body so that they can make the psychological, relational, and sexual changes that are crucial.
So then a lot of problems that people might have is lack of information?
Tremendous lack of information. And it's a paradox because we have actually more and better sexual information we've ever had, and we also have more new performance-oriented myths that leads people tremendously astray. And the best example of that is the pro-sexual medications and how they're advertised.
Yeah, I'm wondering, I studied sexuality, and I learned a model called PLICIT.
Right, Jack Gannon.
Yeah, and the PLICIT stood for different things, like P stood for permission, LI for limited information, SS for specific suggestion, then IT for intensive therapy. Is that still a relevant model, that you can give people permission and information and suggestions and solve many of their sexual problems?
Right. I think you don't have to do couple sex therapy or individual sex therapy. Then in fact, if you give them a pro-sexual approach, give them good information, and make some specific suggestions, it'll eliminate a lot of the sexual concerns. Let me say one of the things that is somewhat controversial, but I believe in very strongly, and that is that rather than the therapist being value neutral, I'd like the therapist to be pro-sexuality. Not to coerce the client, but to say to the client, you want sexuality to play this healthy 15 to 20% role in your life and in this relationship.
So you really need to advocate that and say, this is normal, this is healthy, this is important?
Right. You want to say to the person that sexuality is a good thing in you, in your personality, in your life. And so the question becomes, at this point in your life, how you can express your sexuality so that it really does enhance your life in this marriage.
Okay. Let's go on to a clip that begins with you asking her if the heart attack was a surprise.
Okay. Was his open heart surgery a real surprise to the two of you, or did you see it coming?
It was a huge surprise to him. I saw something, I knew something was wrong.
Okay.
I didn't know what it was, because I went through all those things where I thought it was me. I thought, gee, I'm not desirable anymore. Gee, I'm not sexy anymore. He would say things like, gee, I'm just a really visual guy, and, you just don't look as beautiful as you used to. And I, take that to heart. And then I think about it going, wait a minute. It's like he's pushing me away for some reason, but I don't know what. And I would tell him, I said, I still feel wonderful when I'm not around you. And and that's not being mad to him. I said, I still feel like, hey, I'm okay. And then I get around you, and it's like I'm not 35 anymore.
Right. Neither of you are 35.
Well, no, I know we're not.
Right.
And I think it's unrealistic to do that. But now, since he's been sick, I realize he didn't know what was going on, and that was his way of pushing me away and not needing him so much, because what if he wasn't there? And we've talked about that since. And he still is scared about that, about dying, and leaving me with the two little guys.
So Barry, why would you ask if the heart attack is a surprise? Was that an important question?
Well, I think it is an important question, in that what happens with most men in their 50s is that a heart attack is unexpected, and it really shakes them psychologically, physically, and sexually. And it sounds like that's happened here, and both of them, she was more prepared for it than he was. And clearly he hasn't recovered from it. That's one of the factors in trying to unwind the whole relationship issue plus the sexuality.
Now, she seemed to have a pretty interesting explanation of really why he rejected her. Now, do you pay attention to that?
Well, I do pay attention to it. And that one of the things that I worry about her explanation in terms of going forward in this case is that it's insightful, but it's too simplistic. One of my favorite concepts is that sexuality is multi-causal, multi-dimensional, with vast individual differences. And these simplistic explanations get us in trouble. And especially what gets us in trouble is it says it's my spouse's problem.
Yeah, I noticed that.
It's got to be, you've got to look at your role, he's got to look at his role, and the two of you need to work together as an intimate team to successfully address the issue.
So her explanatory model has really got to change and broaden to include everybody and a lot more factors than she's including
more
right
factors.
now.
And the notion says she has to be more responsible for her own sexuality. He has to be more responsible for his, and they've got to work together as an intimate team.
You know, it seems to me that growing older is really a big source of the problem here.
Actually, what growing older does is it makes sex more challenging. But if you meet the challenge, in the long run, you're going to be able to be sexual in your 50s, 60s, 70s, and 80s. And that's really a joy. That sex becomes more intimate and interactive over time. And ultimately, I think it becomes more human.
But it seems like we're getting the advertisements, such as with the different drugs to help men with erections, and other advertisements that are focusing on trying to stay in a sexual relationship as adults, as if we're 20 years old.
Right.
Is that wise?
It's very, very unwise. Now, the pro-sex medications are actually excellent medications, but they probably cause more non-sexual marriages and more non-sexual relationships than anything in history. Not because they're not a good medication, but because it's setting unrealistic expectations, and it doesn't talk about how to integrate the medication into the couple style of intimacy, pleasuring, and eroticism. And that's why it's backfiring for many. It's causing as much damage for people as it's causing other people to be helped by it.
Oh, wow. Well, let's move on to another clip. And in this next clip, you're going to be giving information to Alita.
When you think about the year before your surgery, so we're talking about 5 years ago.
Oh, huge difference.
How often would you all be sexual?
Every other day.
Okay, so
We
that's
were
a
one of
good,
those couples.
healthy rhythm.
Oh, yeah.
And between your surgery and his surgery, what was the rhythm, what was the frequency of sexual contact?
4 or 5 times a year.
Okay, so it's a dramatic difference.
Dramatic.
And since his surgery, you've been sexual once.
Yeah. Do I like it? No. That's why I'm here.
Right.
Yeah.
But let me say one thing kind of to reduce the stigma. And that is the operational definition of a non-sexual marriage is being sexual less than 10 times a year. And about 1 out of 5 married couples have a non-sexual marriage. And when couples stop being sexual, it's almost always the man's decision. That he feels either too scared or too frustrated or too upset and says, I just want to back away from this.
Okay.
So what you're experiencing is difficult, and you shouldn't necessarily just accept it as difficult, but it's not as infrequent as you might think it is. There's also one of these cute one-liners, and cute one-liners, of course, are always way too simplistic, and that's the concept of use it or lose it, that the more couples stay away from being sexual, the more they become self-conscious. And it sounds like that has happened in the last 5 years.
Yeah.
So, Barry, what are you hoping that this information will do for Alita?
Well, I think that one aspect of sex therapy is to give good information that's scientifically and medically accurate, and that it normalizes the problem and reduces the stigma
mean, so you don't feel so different? You feel like you're the
don't feel
only
so different.
person in the world that has this kind of problem?
Well, in the United States now, there's this notion everybody's doing so much better sexually, except you. And that's not the truth. The reality is sexual problems, especially desire problems, are very common, very, very common.
Now, you said, she, needed to use it or lose it. Is that really true? Do we, have to keep practicing?
Well, sex is like anything else. It's like walking. It's like looking forward to going to movies. You get into a rhythm of being sexual. When you break that rhythm, you become self-conscious, and self-conscious is really bad for people's sexuality. So, both physically and psychologically, you do want to keep a rhythm of touching. That doesn't mean all touching goes to intercourse, but that you do want to keep some rhythm of contact.
So, but do you really lose it? I mean, they haven't done it for a while. Is it gone? Can it be brought back?
It can be brought back, and she uses a concept in the session about rehabilitation. It's a very good concept. If you haven't done any running, you don't all of a sudden go out and run a marathon. You build up to that. So yes, people can rebuild sexuality in their 50s, 60s, 70s, and 80s. But they can't compare it to the way it was in the past, and they can't expect it to be an A performance.
Okay, well, let's go on to the next clip, and she does talk about things getting better and talks about how she thinks things are going to get better. Let's watch.
Okay.
My projections for fixing it will be once he comes to terms with himself and getting healthier and getting happier, he'll be more open to getting that part of our lives back.
And meanwhile, what are you hoping that you'll do, what your role in this will be?
The role I have now. I'm his wife. Would I like it to be different? Yeah. Do I think that now is a different season in my life? Yeah, I do. Do I want to get back to where we're far more sexual and fun-loving and the freedom with that? Absolutely. Do I think it's reasonable to think it's going to happen tomorrow? No, it's not going to happen tomorrow. Do I think it's going to happen? Yeah. Yeah, I do. But I think there's a lot of things that need to get worked through, and I believe that's going to happen within the next year.
She seems to think that it's his responsibility and doesn't really see her own role in it.
Alita is a very interesting person, and she has some excellent insights, and she falls into some very unhealthy traps. And one of those unhealthy traps is that it's hard to get her to think about what is her role. What can she positively do, both for herself as well as positively influencing him?
I mean, it might be comfortable to think things will get better when he changes, but it's probably not very practical.
No, it is not practical, and it sets up something that is really unhealthy, which is they get into a battle of blame and counter-blame.
Oh, yeah.
And sex becomes more about performance than it is about pleasure. That one of the themes over and over again is the essence of sexuality is pleasure-oriented touching. That's the essence of it.
Now, when I was trained as a couples therapist, we used to say sex was the barometer of a good marriage. What do you think of that statement?
I think it's certainly true in some cases, but it's basically absolutely a myth.
Oh.
That there are some
glad I
couples who
asked.
are loving couples who sex really drains their relationship. There's some terribly abusive, negative couples where sex is the only thing that works in their relationship. The old view of marriage therapy, and I was trained the same way you were, that you work on sex indirectly. You work on the other things, the family of origin things, the communication things, the power things, the money things.
It just happens.
And then sex will just happen.
Yeah.
And I think all those things are very helpful. I very much believe in relationship and marriage therapy. But much of the time you have to deal directly with the sexual issue, especially where there's lack of skill and a lot of avoidance. You've got to deal directly with sexuality.
It seems like this is most important, or so important, as people age too, because the rules change.
The rules do change. And if you play by the same rules, you're going to become the statistic. that you're going to be the one who stops being sexual. It's not a choice, it's not verbalized, it's just that sex is more of a frustration, a failed performance. When you think about sex as this combination of intimacy, non-demand pleasuring, eroticism, with realistic expectations. And it's harder for men than for women, because men are used to every time they're sexual, they have successful sex. When you think about the typical 50, 60, 70-year-old, it's a different criterion. It's good enough sex, which means 85% of the time it will flow to intercourse. And when it doesn't, rather than panicking, you have an erotic backup scenario and you have a sensual backup scenario.
I'm not sure what you mean by that. Can you give an example of what an erotic and a sensual backup strategy might be?
An erotic one is when, in fact, you're not going to be able to have intercourse for whatever reason. That you switch gears to focusing on manual stimulation or rubbing stimulation or oral stimulation for high arousal and orgasm for one or both people. And a sensual situation is, rather than turning over and not saying anything, it's a way of cuddling again, of reconnecting, of feeling warm and close and intimate, and being able to say in the next 2-3 days, let's come back to this, rather than leave it with a bad taste in our mouths.
So it's sort of like the halftime before the next time.
Right.
Yeah.
That's a great analogy.
Let's move on to where you use some questions and you get very specific into her sexual patterns.
Right.
Okay.
Right.
You know, and then when you do get...
What was the one way it used to come for you?
When I would get aroused, you'd become wet, you know, things would swell, that it would get comfortable. You know, your body would feel good.
Right.
And now...
And your orgasmic pattern was easy and reliable?
Oh, yeah.
And typically, was your orgasmic pattern during manual stimulation or oral stimulation or intercourse stimulation, or all those kind of stimulations?
All three. You know, I could think of myself into it.
Okay.
You know, and it wasn't ever fake. You know, you hear about people faking it, and I never did. I never had to. You know, and after the hysterectomy, it's like I went to go use the car, and the car didn't run anymore.
You know, Barry, you had to get very, very specific on a topic that often is considered taboo.
Right, but that's one of the special things about sex therapy. You don't want to be coercive on one hand, nor do you want to be voyeuristic, but you need to be specific if you're going to help the person assess and change their sexuality. So you can't be so shy or inhibited that you don't allow you and the patient to be talking about the same experience and the same attitudes and feelings about it.
I mean, for some people, what she talked about is so private that they don't even know that it's there. I mean, she's so forthcoming.
Right. No, she is much more forthcoming than most clients.
But what about somebody who is the private kind of person that I'm talking about? What do you do with them?
With that person, there's a number of ways to get them to interact about this. You can give them reading material. You can give them audio-visual material. But probably the most common thing that I do in my office is that what I do with them is that I will talk to them about different sexual scenarios, and I will lay out 3 or 4 different sexual scenarios. I will talk about, for example, whether they prefer multiple stimulation or single stimulation. I'll give examples of that. And then at the end I'll say, now as we've described that, do any of those fit you, or is your pattern totally different? So it allows them, again, a way of reacting so that they're able to express things that are important for them to express.
So you structure it a little bit, give them a multiple choice question rather than an open-ended question?
You can do it open-ended or multiple choice. What you shouldn't do it is a yes-no.
I see.
You know, let me give you a quick, funny example. When we adopted our child, it was much easier to have biological children to adopt. It was harder. And they asked very comprehensive questions. I was very impressed with it. And then it occurred to me they didn't ask me a single question about sex. When I asked my wife what they asked, said there was one question. There weren't any sexual problems, are there? I mean, how could you say anything to that? You're asking the person to avoid the issue.
Yeah.
And I think what you want to do as a good clinician is you want to make talking about sexuality comfortable and talking about their anxieties about it comfortable too.
Yeah, but the problem with that, I think, Barry, is don't we have to be comfortable ourselves? And how does that happen?
Well, again, I think part of that comes intellectually from taking courses, from reading materials. There's excellent materials out there about sexual interviewing and asking questions about value-oriented issues. But I also think it comes from the experience of supervision, whether in a group or out of a group. It comes from going to conferences where you might be taking a sexuality program or a sexual attitude readjustment program that allows you to experience sexuality as something that is a healthy part of life and that fits in, and finding your own value system about what you're comfortable, what you're not comfortable with.
And I would think some people might think you're being nosy or you're poking around in a private area or...
Well, that's why it's important from the beginning to be sure and say to the client, I always say to clients, there's never any touching in this office, there's never any nudity in this office, that all of the sexual exercises are done in the privacy of your own home. And that I always tell them also that I want to respect your value system. So if at any point you feel uncomfortable or you feel this is something that doesn't fit into who you are, just give me a timeout and I am glad to move away from it. That the goal here is to find your unique sexual voice as a person and as a couple.
Okay, the next clip we're going to look at, Barry, is a little bit past the halfway part of the interview. And what you're doing here is you're giving assignments already and specific suggestions for Alita. Let's watch.
Good.
Yeah.
Would you feel strange finding a gynecologist or an endocrinologist who was pro-sexual, who you could comfortably talk to, where he would come with you to the appointment? You'd have to do the exercise.
Oh, it'd be fine.
See, I think that could be enormously helpful, where you're both dealing with the same information. And part of that information is that for the great majority of women over 40, but certainly almost all women over 50, that even when they're feeling subjectively aroused, their body simply doesn't respond as easily objectively. That's true of his penis and his erection. That's true of your vulva and vaginal lubrication. So that one intervention that people often do is they get comfortable with using a lubricant and using it prophylactically. In other words, using it before you begin the sexual experience. And
I've done it. Go ahead.
And what I often suggest people to do would be to choose a lubricant together, to go together to a place like Crabtree and Evelyn. If you don't like that kind of place, go to your local drugstore.
The almond oil.
Right.
Yes.
Find something which is water-based, hypoallergenic, and it feels and smells good. Not instead of stimulation, but in addition to it, and doing it before you all begin.
One of the things that I know he enjoyed and I enjoyed is when he would go down on me.
Right.
And when you use the lubrication ahead of time, then we were using oil and
oil is usually not a good thing
yeah,
to use.
because it's
but
not any good that way.
in terms of doing oral sex, again, one of the best predictors of sexual response is feeling open and responsive to oral sex.
Are assignments, or maybe I already know the answer to the question, but are assignments a big part of sex therapy?
In the way that I do sex therapy, I think the majority of sex therapists work, that is one of the biggest issues, is about semi-structured assignments between sessions. And ideally, the people would do 1 to 4 of those assignments between the weekly sessions.
So the work really can't take place in the conference room, and it needs to take place outside.
Right. Well, it's both. It's a both-and approach. It's important to talk about the attitudes, the feelings, the experiences, and process them afterwards. But that's right, you've got to have the experiences. That one of the things the exercises do is they help engage the couple in the change process.
Yeah, I noticed that your assignments were for two, not for one. Do this with your partner.
Right. There are assignments for one people. I mean, people can do this alone. You can do sex therapy with individual clients, but it's more impactful and more successful when it's viewed as a couple issue.
One of the things that I also realized as I watched you work, you really have to have an enormous amount of information and a wealth of strategies and suggestions. Where do we get this?
Well, again, one of the nice things about this profession now is that we have more information medically, we have more information in terms of sexual response, and there are some good psychoeducational videotapes out there. Much of what you're going to see at Barnes & Noble is actually, I think, silly and misleading in terms of sexuality. But there are some excellent sexuality references that clients can get. And sometimes they're going to have to go on Amazon to get it because it won't sell at the bookstore. But there's good stuff out there.
So some information is still misleading that's out there in the popular press?
When I go to Barnes & Noble, I feel a combination of embarrassed and intimidated.
So you're not into the Kama Sutra and all of these other
The Kama
kinds
Sutra
of
is
things?
better than most of them.
Yeah.
This idea of the multi-orgasmic
Right.
couple, how to have an orgasm every time, sex perfect 360 days of the year, that sets unrealistic performance demands, and you wind up feeling like you're the only one who's failed at it.
Yeah, it almost like when you go there, you don't feel very good sexually when you look at some of the things you see that you or probably nobody else can do.
And I can't do them. And if I can't do them, why do you expect your client to do them?
Sure, yeah. Let's move on, Barry, to a final clip. It occurs right near the end of the session when she, as we say, dropped a bomb.
Right.
Let's watch.
I do remember the bomb.
I threw him out 2 weeks ago and packed all his clothes. He wasn't listening to me. He wasn't listening to himself or anything, so I packed everything he owned neatly, but put it in suitcases and took it over to, he was spending all his time at the office and not coming home, and put it in the car and said, look, I think you need some time by yourself, away from us, away from making us miserable and yourself miserable, and figure out what you want for your life, and if you want to sin it, fine, and if you don't, fine too. But this can't go on like this. And I didn't, go after him for 2 days. He's home now, but he still just looks at me and goes, you took all my clothes out of this house. And I'm like, I needed to kind of what you said. It's like, I want him to make decisions. I want him to set goals for us. And through those things, I think the self-esteem will come back to where our sexuality will come back. But somebody had to stop it.
Sort of the tough love approach.
Yeah,
Barry, you really look surprised that this came about. What were you thinking?
Well, I was totally surprised. It's absolutely true. It's also a good example of where the client and what's happening with the client is more important than your theory or your techniques. That you had to take that in, and you also had to say, okay, you've done something dramatic to make a point, and now what are we going to do next? And I think in many therapists, when they hear that kind of drama, they totally drop the sex. And what I try to do is I try to deal with both of the feelings, what's going to happen next, but not let the sex go. And that's one of the difference. Sex is not the only or most important thing in people's lives or relationships, but you don't want the sexual issue to go.
This new issue doesn't become a smokescreen and cover up the work that you've been talking about.
And then totally lose track of the therapy contract. You want the therapy contract to include sexuality.
I've learned an awful lot from watching you work and hearing you talk about your work. Are there any final comments that you might have for our viewers on doing sex therapy with middle and older age clients?
Well, the major one, I would encourage more and more clinicians to become involved in the sexuality field. And it doesn't mean, I love the Plicid model. So that I would love all clinicians to be good at permission giving and limited information and be able to make specific suggestions. And if that isn't helpful, then make a referral. But the message has to be that sexuality, as you reach your 40s, 50s, 60s, 70s, has got to be more intimate and more interactive and more pleasure-oriented. And I think that's one of the fun things about doing this kind of work.
Wow. That's very, very good advice. Thank you very much, Barry.
Thank you.